Well, welcome everybody. So happy that you're joining us. I'm Neal Shore. I'm a urologist, and I'm joined today with two really great colleagues. One is Alicia Morgan's on. We'll show a slide in a second, but she is a phenomenal medical oncologist. I'm a urologist, and together with Aicha Diallo, who is vice president of programs, a patient empowerment network, which is really the thrust of this program today, and the importance of what does that mean and how do we empower patients. And we're specifically going to focus in on advanced prostate cancer care, which affects so many patients today. Prostate cancer is the most commonly diagnosed solid tumor malignancy in the US, lung cancer being number two. So it's a great pleasure to be with you today. Alicia Morgan's, her affiliations, Aicha Diallo, two really experts in the field of enhancing conversation and communication with patients. So I'm really honored to be part of this program. Here's our agenda. Let me go through this not too quickly, but just to sort of a level set. And then we're going to go through a case, and we're going to have time at the end for you to send in your questions. And there are only good questions. There are no bad questions. So please send them in, and we want to answer all of them if possible. One of the things that we talk about now, and I love that, Alicia's been really pioneering this with several of our other colleagues, is this very important concept of shared decision making. Historically, I think, and at least in the arc of my career, we've had this sort of paternalistic approach in the medical community. I'm the doctor, I'm wearing a white lab coat, I'm going to tell you, this is what you're going to do. Well, that just doesn't work. That is completely over. It's really now about the burden is to make the doctor a better communicator with the patient. And that's complicated. And I think Aicha is going to really get into her expertise on this too. How do we communicate better? How do we have the talk tracks, the narratives, so that we're not, paternalistically saying, I'm the doctor, you listen to me and this is what goes. And there's a lot of, amazing advancements now in cancer care. We're going to focus on prostate. So I think the concept of shared decision making, at least in my humble opinion, is as a physician, as the healthcare provider, and it could be the nurse, it could be anybody in the healthcare system you're involved in. There's a big team now. There are a lot of folks. It's not just medical oncologists and urologists. There's so many other people involved. But saying, look, I want to be able to communicate in such a way that you, Mr. X, and your partner and your family members, that I can communicate it so that you ultimately make the decision. And I think this makes for much happier patients and families when they're much more involved. I think that's, to me, is one of the biggest impacts of shared decision making, so that there's not regret, like, oh, why did I do the surgery over the radiation, or why did I do the chemo over the hormonal therapy or radiopharmaceutical. So it's all about this shared decision making. And I think language is amazingly important. There's different languages for different educational levels. There's different languages for generations. There's socio-demographic, ethnic, racial backgrounds. And I think we're all learning a lot. And so I think Aicha and Alicia are going to really be able to weigh in tremendously on this. So why does it make a difference? Well, first of all, I love that the centerpiece here is it says patient-centric. And if you're in healthcare, it's all about the patient, right? I mean, we do truly believe that. Everybody does. But, physicians and other healthcare providers get a little bit in the weeds sometimes when they get stressed out in their daily existence and burdensome of regulatory and bureaucratic stuff. But still, that's not an excuse for saying we always have to do what's in the best interest of the patient. Cancer is a scary thing. It's oftentimes a fatal process. And so we have to do what's best in shared decision-making for patient-centric care. And it's really putting the patients at the top of the pyramid or in the center of the wheel. And I think that I've learned so much from folks like Aicha and Alicia, and how we all, do things differently, whether it's in a community setting, an academic setting, a rural setting, a suburban, urban setting. So we're going to go into this really fascinating case, and we'll have a presentation and the history. And a big part of it, I think, is what are the goals? How do you prioritize those goals? How do you understand and rank priorities? How do you do what's called, I think, preference value? Are you more risk averse? Are you more risk tolerant? And a lot of that comes down to the fears. What are your fears? Sometimes they could be financial. Sometimes they may be a side effect issue, maybe a dosing administration. It could be transportation. There's so many things, and we'll talk about that. So I'm thrilled to be here with Alicia and Aicha. So let's turn it over to you, Aicha. Let's talk about this case, and we're going to have time at the end, hopefully, for some great questions.
Thank you so much, Dr. Shore. So, a little bit about our patient, Arthur. He's 67 years old. He moved to the United States from the Dominican Republic in 1990. He is a U.S. Navy veteran. He was naturalized with his U.S. citizenship in 2000. He's a retired machine operator. He enjoys his hobbies, loves life. He likes to go golfing, bowling, and casino gambling from time to time. He is married. His wife is Anna. She's 42 years old. I'm sorry, they've been together for 42 years. They have two children, two adult children, and three grandchildren. So, as you can see, he is full of life, wants to enjoy his life, wants to have the opportunities to be present for his family and to be there. So we will dive a little bit deeper into the case and tell you a little bit more about his diagnosis and where he is. And we will dive into the shared decision-making aspect of it and how we can help him come up with the best treatment option for him and his family.
I love that you have this detail about his interests and hobbies. Alicia, how do you incorporate that? You're practicing in Boston. I'm in South Carolina. You and I just came from a big international meeting, of all places, Las Vegas, where we were surrounded by casinos, and there are a lot of golf courses there too. But how do you use the patients, and where do you put that in the landscape of maybe a first visit and subsequent visits, the patient's interests and hobbies? Because I guess what I'm building in the question is, we don't always just jump right into the lab values and the imaging, right? It's kind of humanizing the conversation.
Absolutely. So I think that it is so important to understand what people do. And I usually think about this from a lens of who are they, but also how do they get physical activity? Because as a doctor, I want to make sure that they're physically active, that I can help them understand, well, how do I improve my health also by increasing my physical activity? And these questions about hobbies and interests give me opportunities to, one, bond with the person, because a lot of things that people like to do, we all like to do. And then two, say, oh, you love walking your dog, you do that every day, why don't you walk a little bit farther? How can we help you to sort of increase some activity around that? So doctors are often very focused on what can I do for your physical health, and sometimes also we always should be thinking, but we don't always acknowledge that we also should be thinking about mental health. Hobbies and interests are often a sort of common bond for us to harness what makes people happy, and kind of use that from a medical perspective as well. So I do that. To your point, I talk to people on their first visit. I often talk to them in their follow-up visits, especially as we're talking about, where are you traveling? What are you doing for the summer? It not only humanizes people, it helps cement these individuals in my mind. We have common interests and common bonds. It gives me great ideas for things I can do with my family too. And I think helps everybody come together as people, not just as doctor-patient. But then also gives us this opportunity. Can you walk for a couple holes and let your buddy drive the cart? That kind of how do we help improve your physical health too, as we're thinking about what makes you happy and what your hobbies are?
I think it's so important to be able to learn a little bit more about your patient, find out more about their families, their interests, their goals, their wants, their needs. I think it really shapes the direction you take in terms of coming up with, as a team, with the best treatment option for them. And it also establishes that trust, right? The patient looking at this and being able to feel seen, and to know that the healthcare team as a whole does have an interest in them, in their life, and that what they are talking about very much reflects and is present and is considered. I think that's very, very important to consider in the beginning when you do see your patients. So I love that you do that, Dr. Morgans.
Thanks.
Yeah,
And it makes it so much more fun too for us. I mean, we want to help people's health, but we love just connecting with people. And this is one of the ways that we do that.
Absolutely.
I think that's so, with commentary is great. And, and in some ways, I was just thinking, Aicha, sometimes I think the patients have to sort of recognize when they come in, maybe does my doctor look, or is he or she seemingly, harried, hassled today? Maybe they're just inherently not the warmest personality. But they could be amazing physicians, right? They could be great diagnosticians and great in therapeutic management decisions. Sometimes I think we realize now, that we all have an opportunity to make the other, person we're working with be a little better, and be a little kinder, and be a little bit more humanistic. So, do you have any tips or tricks but it's hard though when you're the patient. It's intimidating. You're walking in, and it's like this doctor, and what would be a way to try to engage the physician who's not inherently warm and charming and friendly like Dr. Morgan's?
Yeah, that's a great question. I often talk about this concept of cultural humility, in addition to the cultural competency that we all learned as healthcare professionals, as providers, that we learned back in our training. But what's really important, and we touched on that, we talked about that trust, we talked about the conversations. And sometimes, yes, you do walk into your doctor's office and they may not be the friendliest. They may not ask you a lot of questions about you. And it does create a barrier for the patient. But I think it's all about that relationship building. Maybe with the provider, you only have a few minutes. Maybe he's not the person, or she's not the person that you will really engage in and have longer conversations. But as long as you feel that they do have some sort of interest in you, in your life, in wanting to hear about your concerns, even when they ask, do you have any questions? What are you doing this weekend? Where are you from? I think that makes such a big difference, even if they're not the warmest or the most or that don't allocate a lot of time. But I do think, though, that it is extremely important, and patients can see that when their healthcare team takes some time to really listen a little more, show respect. And that's the core pretty much of cultural humility. Stay humble, avoiding assumptions, and really ultimately providing that care that aligns very well with the patient's needs and wants. I think it goes a long way to say, what are your goals? What would you like? And even when the healthcare team does know a little bit about what their hobbies are, so that would guide that direction. But I think it's important for patients to understand that they do have that seat at the table. I often refer to patients as the leaders and the CEO of their own care. So if you are at the center, you're sitting at that table, you do have the opportunity to really guide that conversation with your healthcare team and feel seen and present. So I think it's just very essential to make sure that patients understand their powerful voices.
100%. Okay. All right. So, Alicia, here's a case. You see many of these types of patients. I know I do too. Could you please present this? Did we lose your? I'm not hearing you. I don't know if it's me.
We can hear you, Dr. Morgan.
Okay.
Better now. We can hear you.
Hear me? Okay, very good. Thank you. So Arthur is ultimately diagnosed with mCRPC in March of 2022, and his disease characteristics we can see on the screen. So he has multiple bone metastases, and PSA is 20, Gleason score is 7. He actually feels pretty well with just mild symptoms of bone pain. Physically, he has an ECOG performance status of 0. So,
Whoops, we missed you there.
No worries.
So I shall probably come back in a minute. And ECOG for the audience that's like high performance. Oh, there you are. You're back, Alicia.
You're back. We can't hear you.
We're seeing you, but not hearing you. All right. So a performance, once Alicia gets back, I'll just pick. So a performance of 0 is actually the best, right? It's like you're completely, functional and fit. This gentleman is on no medications. Just let us know, Alicia, when you're back on. And then essentially it got started on a course of chemotherapy. You see that listed here. This is docetaxel, and also a therapy to lower the male hormone called degarelix. It's a subcutaneous injection. And then also underwent radiation therapy, that's like EBRT, external beam radiation therapy, to a thoracic 12 vertebrae because there was some bone pain. These short courses of radiation can help the patient, but it's interesting. It's already getting complicated. A drug to lower the male hormone level, a chemotherapeutic given every 3 weeks for 6 cycles. This is all standard of care regimen, but works differently from just lowering the testosterone. And he comes back with some grade 1, which are the milder forms, the grade 1, 2, as opposed to the 3, 4s. The grade 1s, nausea and back pain, these are managed with over-the-counter products. So,
can you hear me, Neal?
Yes, perfect.
Wonderful. And I'm so sorry for that. So after his treatment with docetaxel, which Neal expertly presented because he's almost a medical oncologist, he had PSA progression. His PSA is rising here. He underwent genetic testing, germline and somatic, which we know is so important. And his somatic testing, including tumor and ctDNA, showed that he had a BRCA2 mutation. Now, we will find half of these mutations in somatic testing, another half in germline testing. So it's important to do both. He had this testing done. So because of that BRCA2 mutation, which we know is incredibly sensitive to treatment with PARP inhibitors, this patient ended up having talazoparib, which is an incredibly potent PARP inhibitor, and combination enzalutamide here. And this combination we recently saw shows that actually we can have great responses, particularly in people with BRCA2 in terms of disease control. He also continued degarelix, which is the medicine to lower his testosterone, and he also was on prednisone at this time. So in terms of how we tolerated it, I think it's really important for us to recognize in this ongoing conversation with him that he had a grade 3 anemia. His hemoglobin or red blood cell count dropped to a hemoglobin of 8. And he had some symptoms of worsening fatigue and even some shortness of breath or dyspnea on exertion when he tried to do physical activity that he normally would do, even golfing, normally do without any difficulty. His performance status, or that measure of, his overall fitness, declined from really not being limited at all by his cancer or its treatments to 2, which meant that for about half of the day, he was kind of sitting and resting and not being up and active. And this occurred within about 3 months of him starting on treatment. And in terms of his quality of life, he was really limited in terms of his ongoing ability to engage in those golf games, to do bowling, and his bus trips to the casino were curtailed. And he needed assistance with some of the more complicated activities of daily living that he had to do. And he was ambulatory, but again, he spent about 50% of his time kind of sitting or lying down, not being out there in the world, which was his norm.
So this is such a great presentation, and I think that we don't need to get totally into the weeds necessarily of the initial treatment, but I love the fact that he went on to get a cutting edge treatment in combining this drug called talazoparib. It's a PARP inhibitor, and enzalutamide, which is an androgen receptor inhibitor. So these are 2 oral drugs that work synergistically. But I think it's so important, and I'd love to hear you comment on this, Alicia and Aicha. You know, he started to sort of kind of almost involute a little bit, right? Just
Mhm.
not doing anything. It reminds me of this great line from Shawshank Redemption. Everybody's seen that movie like a million times, right? But when he says, "Get busy living or get busy dying," you know, you got to stay active. And I tell this to my advanced cancer patients all the time, whether they're 55 or 95. You've got to get out there and do something, whether it's golf. And I tell patients, you know, you got to do something. You don't like you know, you may not like Pilates, so don't do Pilates. But maybe you like to walk in a pool, or maybe you just want to walk around your block. But you got to stay engaged, physically and mentally. But Aicha, what are some things that you know, for this patient, you know, who's starting to, you know, maybe it's age, maybe it's the therapy. How would you counsel him?
Yeah, it looks like all of the different activities he enjoyed doing in the past just started to go out the window. And I think it's not just obviously we could tell that it's him not being able to do half of these things anymore, right? So it's really thinking about what else do you enjoy, and maybe don't do too much. Maybe think of an activity that you've been putting off. Maybe it's watching a show. Maybe it's playing a game on, on a piece of paper, or maybe on a computer, or maybe on a tool that you probably have. Maybe it's interacting more with your family. So it's always finding something that could replace some of the physical activities that the patient used to enjoy, until they can regain the ability and the interest to want to do that. So it's really thinking about what else can be done.
Yeah. You know, I think it's all these different forms of engagement. It's the physical, super important. There's so much data that supports that, but there's also the intellectual engagement, and for many, it's the spiritual engagement, and finding some level of spiritual joy. And I'm not promoting, you know, a religion or a non-religion, but just feeling that there's some soul in your heart and your family and people that you can connect with. And you
Absolutely.
don't get that by staying home and hanging out on your couch and not getting out and being involved in the world. I think that's an important message, right?
Absolutely. But one very important aspect I do want to flag is it's also the emotional and mental aspect of having a cancer diagnosis, and being now not being able to do all of the different activities he loved to do in the past. So it's also about speaking about it, and we'll get to that barrier in a little bit. But being able to talk to someone at as part of his healthcare team, and understanding who is part of that team. Is it a nurse that he feels more comfortable with, a social worker, or a navigator, or someone that he could really say? Because quite often patients don't come up to you and tell you, I don't have interest in doing these things anymore, right? It's really when you peel of the onion that you really get to the bottom of some of these things that don't always come up during their visit. So maybe by diving a little bit deeper, it could be understood or seen that there's some sort of on the emotional part or aspect that he will probably need some help and need to talk to someone and be surrounded by more support or more love, right?
I want to hear, because I know we're going to run out of time. I want to hear, Alicia, these are some really cool concepts here. But, you know, your point about the healthcare team is so amazing, because and that's why it's a privilege to be a healthcare provider. You know, from people who greet you when you come in to check you out with your billing, and you're exactly right. There's so many unsung heroes. It's not just the doctors at all. It's many times it's so many other people who touch people's inner cores. But yeah, so Alicia, this case.
Sure. So I think just to touch back and to share that as medical oncologists, we should be talking to our patients about these things, and also thinking about the contribution of the treatment to these side effects and these experiences that we sometimes can actually decrease the dose and expect that we'll have reasonable effectiveness still in controlling the cancer, while we might still then be able to help preserve someone's quality of life. And these are ongoing conversations that we have, not certainly something we make a snap decision about. But in this case, the patient, unfortunately, Arthur, really felt betrayed by the change to this combination therapy. He knew it was cutting edge, but
he felt like he felt better on this chemotherapy and ADT degarelix combination, and was really skeptical about how serious was the need for me to change. Did I really even have to do that? He felt like his life was so much smaller, as you said, involuted since he started this. His brother-in-law experienced several really complex side effects during treatment for lung cancer. And Anna was an avid user of social media at the time, and resistant to further treatment. And he was really less savvy than his wife, in terms of that engagement, and just defers to her. But it was complicated. And I think a lot of the conversations in social media could tend to compound some of that complication. And I think we'll hear from Aicha on the next slide about some of these sources of information as well.
Yeah, this is great, Aicha. Take it over here, because social media, big double-edged sword, right? There's a lot of great stuff on it, but a lot of it's terrible. So, where do we find trust? Where do we find authenticity? Not everybody's so lucky to get in and see Dr. Morgan. There's only one of her. We can clone her and make her 10,000, but that's a whole nother topic. But so what do you advise patients and families to do about this?
So there's a lot of considering factors here. We have to highlight the fact that Arthur, there is a family history of cancers in his family. There's a huge mistrust in the healthcare system that takes a lot to be able to establish that trust. And that's something that needs to happen as a team with his healthcare team. He really needs to be surrounded by members of his healthcare team that do speak and understand Arthur's language. And when I say do speak and understand, not only that I'm talking about speaking in Spanish, because that's the language that he feels most comfortable in, but really at the level, at the language that he wants and feels comfortable with, right? So I think it's really important for us to really understand that representation is huge. So he wants to be part of this external family that's part of his healthcare team. And there's nothing wrong with him also considering a second opinion and expanding his care team. That's just in addition to the current team he has. And perhaps there he will find other members of his healthcare team that could really communicate with him and even connect him with a translator to make sure that he doesn't miss anything, and that the language, that the resources are presented to him are simplified or in a way that are clear. The other important aspect is also the digital literacy barrier. It's clear here that his wife, Anna, feels very comfortable with social media. She is tech savvy, but not so much for Arthur. And I'm pretty sure that if he had the tools and support to feel confident accessing credible, and I really do want to stress the credible aspect of it, which I know that Dr. Shore, that's really where you were going. It's important to know that there's a lot going on the internet, but is the information credible? So we really want to make sure that they know the distinction with that, and that they come to organizations like us, for instance, Patient Empowerment Network. We have programs, and other groups, obviously. We have programs specifically on digital literacy. Our Digital Sherpa and Digitally Empowered program really helps individuals become more tech savvy while they're really looking and using reliable online resources. So something like this will be perfect for someone like Arthur, because then he could feel like now he could take this information and take these questions right back to his healthcare team. So it's important for us to really make sure that we promote this as healthcare professionals, and that patients understand that not everything they see online is a reliable or a credible source, but we can link them and allow them to access those credible resources so they could feel more confident and more engaged in those conversations with their healthcare teams.
Yeah, that's great. I mean, we really, and the name of your organization, it really is perfect. Patient Empowerment Network. And I think that's where we have to continue. And there are some other sites too. And this is where patients can do their best. But let's go to this slide, because this is a great case. There's so many things going on in this. He's getting state-of-the-art care, but yet felt disappointed somehow because there were some side effects. So Alicia, how do you kind of put this together in the context, not just of the therapy, which is very important, obviously, that's the ultimate thing, but all these other concepts of of empowerment for the patient?
Yeah, I think from my view, I think number one, we recognize that there's been some erosion in the relationship here, that the patient-doctor relationship, the Arthur doesn't really trust his doctor. And I think any attempts that could be made to solidify that relationship, get the trust back, express understanding that life has changed. This is not what Arthur wanted. Acknowledge the challenges there and say, look, we don't like this either. We want the best for you from your perspective, not just from our cancer control type perspective, from both of our perspectives. Acknowledge that and build the bond back, and talk with Arthur and with Anna about, will you give us another shot with this medicine? Can we try to hold the dose? Can we try to decrease the dose? Is it worth trying to salvage what seems to be an effective treatment? Or should we pivot and go in a new direction, and put that conversation just out on the table to salvage the relationship, and also make sure that Arthur feels empowered and participatory in that treatment conversation. So that would be the number one. I do think this is a highly effective treatment combination. And for people with BRCA2 mutations, if we can get this drug into them and do it in a way that they feel they can tolerate, this from a cancer control perspective is ideal. But ultimately, Arthur's the person that lives with this disease, and Arthur's the person that lives with the treatment. And so we really need to meet him and Anna where they are, and restoring the trust, the relationship, and moving forward together, I think, is probably the most important thing.
Absolutely.
Well, I think that was beautifully summarized and said. And, the 30 minutes flew by to me like it was 30 seconds. I think we could have talked. I enjoyed this so much. Could have talked for a couple more hours on this. We answered some of the questions. We didn't get to all of them. I apologize, but I just want to say I really think that this is the reason why so many physicians and nurses and administrators go into healthcare, to do better work. I think your organization, Aicha, a Patient Empowerment Network, and the exceptional work that Alicia Morgans is doing on shared decision-making in many different fronts and many different assessments of patient-reported outcomes. This is how we do better in the world. And the North Star is ultimately taking care of patients. So I want to thank you both very much. Great presentations. I wish we had more time. This was a lot of fun. Thank you.
Thank you so much, Neal.
Thank you so much for having me.